Pleased to introduce to you Dr. Ciara Kelly. Dr. Kelly is a medical oncologist at Memorial Sloan Kettering Cancer Center in New York City, who has expertise in treating and researching bone and soft tissue sarcomas and Merkel cell carcinoma. She works very closely with a team of medical oncologists, surgeons, radiation oncologists, nurses, and patient support advocates. Dr. Kelly's research aims to develop new and more personalized therapies to treat sarcomas. She is actively involved in developing and designing clinical trials that will look at novel agents that target molecular changes within tumors. She is also studying innovative combination immunotherapy options that will harness a person's own immune defenses to fight their cancer. Dr. Kelly has a particular interest in advancing understanding of gastrointestinal stromal tumors and other sarcomas at the molecular level. She's using liquid biopsies to analyze tumor DNA in the blood and tumor biopsies to uncover a biomarker that will ultimately help match the best treatment option with each individual person's tumor. Dr. Kelly will talk to us about circulating tumor DNA in GIST and its implications on treatment. Thank you.
Thank you, Mark. Thank you, Mark. Thank you very much for having me here today. It's actually really important for me also to listen to you and to learn. And as I said to Sarah earlier, I find the results of your survey enlightening. And I hope that I can touch and give you some insight into the topic of circulating tumor DNA in GIST and its implications on treatment. And I probably should have put potential implications on treatment as George or as Bill and Suzanne touched on earlier. This ctDNA in GIST is really in development, and it still needs a lot of work and validation before it actually hits mainstream for GIST. So the objectives of the talk, what I want to go over with you this morning, really firstly to give you a bit of a background of as far as what is a liquid biopsy and ctDNA. Go through the methodology for extraction and downstream analysis of ctDNA, and some recent ctDNA advances in oncology, and also then touch on the role, the utility of the potential utility of ctDNA in GIST and the current available evidence that we have. And then the future directions where we need to move towards. So just by way of background, what is a liquid biopsy? It's really the detection and analysis of tumor-derived material from bodily fluid. It can include looking at circulating whole tumor cells, exosome, which are membrane-bound vesicles that contain particles of cells, and then DNA from tumor cells that have been secreted and shed into the bloodstream following cell death and necrosis. And it's important to understand the distinction between circulating tumor DNA and cell-free DNA. So ctDNA is a component of cell-free DNA. And cell-free DNA reflects the fragments of both normal and cancer cells that are shed into the bloodstream. And ctDNA reflects the tumor-derived material in the bloodstream. And so sources of circulating tumor DNA are not only just in blood, you can also potentially detect it in urine, in cerebrospinal fluid, and also respiratory secretions. So, for example, how do you collect cell-free DNA from a blood sample? Well, it's very simple. You take some blood, a small amount, in a tube called a Stark tube, which allows for a separation of the plasma. From there, we then extract the cell-free DNA. We can quantify the amount of DNA present, and then we can also then move forward to downstream analysis. However, it's important to recognize here, if you can introduce a quality control step at this point, it's really helpful. So a quality control step would be to take a normal matched blood sample that you can then also use to sequence in a downstream fashion. So the downstream analysis of ctDNA facilitates the sequencing and detection of the tumor's genomic landscape. And so you can potentially look at copy number changes such as amplification and deletions, chromosomal changes, translocations, and in particular point mutations. And there are many methods that we have currently to do this. The most familiar, the ones that we're probably most familiar with are PCR-based, which are the more standard methods for testing ctDNA. However, the issue with, let's say, for example, digital droplet PCR is that you need to know the mutation that you're looking for. Whereas in other methods such as sequencing, gene sequencing, whole genome sequencing, next generation sequencing technologies, it allows you to look for what you expect to find, but also potentially find new mutations that you're not expecting, which has importance particularly in the setting of, wanting to learn about other resistance mechanisms other than those which we know already. However, when you use a large panel of genes to sequence this material, the sensitivity often can reduce. And so what may be the most effective method may be a targeted panel, which allows for some discovery but optimizes the sensitivity. And so ctDNA in GIST, I feel, has the potential to become a blood biomarker, and it may fall into three different categories of biomarker. One, it may be predictive, in that it can highlight a characteristic of the patient's tumor and then categorize them based on this in terms of their likelihood to respond to a given therapy. It has the potential to be pharmacodynamic, in that it can provide a dynamic assessment showing biological response to a therapeutic intervention, and then also has the potential to be a discovery biomarker, identifying previously unknown genetic aberrations that may promote tumorigenesis and resistance to therapy. So as I said earlier, a quality control step is really important because this helps to optimize the sensitivity of detection of genetic aberrations within ctDNA. So I spoke about, the ability to collect maybe a normal matched germline sample of blood in parallel with your cell-free DNA. And by sequencing both of these materials, you can, and comparing the results, it allows for unambiguous detection of tumor-specific DNA. Another way, though, would be when you sequence your ctDNA and you fail to show any genomic changes. Is that because there are no genomic changes, or is that because, let's say, the sensitivity of your method isn't good enough to detect the genomic changes, or that there isn't enough DNA material there to yield a result? And so, unfortunately, in just this step is a little bit more challenging, but we may be able to improve on this. So, looking at ctDNA advances in oncology as a whole, this was a huge important step in this technology. In 2016, the FDA approved a COBAS, a PCR-based EGFR mutation test in plasma specimens as a companion diagnostic test to detect specific EGFR mutations to identify patients with a specific subtype of lung cancer that are eligible for a targeted treatment, Tarceva. So, lung cancer includes a subtype called non-small cell lung adenocarcinoma, and of this, about 10 to 30% of these patients with this tumor type their tumors will harbor EGFR mutations. And in 2013, the American College of Pathologists published a guideline stating that all patients with this type of tumor diagnosed in a metastatic setting should have their tumor tissue tested to detect this specific mutation to see whether they'd be eligible for a targeted therapy called Tarceva. And it was really on the basis of this study called the Ensure study, which was a was a phase 3 randomized open label study that looked at erlotinib, which targets EGFR mutant adenocarcinoma in lung, versus at that time the standard chemotherapy in patients with advanced EGFR mutation positive non-small cell lung adenocarcinoma. And this study had the foresight to collect plasma samples from patients together with tumor specimens at the outset of the study, very similar to what has been done in the Decipher study and Blue 285. And so in this study, 99% of the 217 patients enrolled had tumor tissue and plasma samples available for analysis. And they then performed PCR-based molecular testing on both of these sets of samples. And they were able to show a high concordance between the COBAS testing detecting EGFR mutations in tissue and plasma. For example, 77% of the tissue-positive specimens, the plasma was also positive. And in 98% of tissue-negative specimens, the plasma was also negative. So very high specificity and sensitivity, pretty good. And so this sets a real precedent. So we can potentially replicate this, perhaps in the GIST setting. We can bring the ctDNA technology forward as a companion diagnostic test for some of our novel therapies. So what is the potential role of ctDNA in GIST? Well, in the localized setting, I think it has the ability to potentially detect minimally residual disease and give us more information perhaps on the potential risk of recurrence for patients, and therefore guide therapeutic selection, and also potentially detect recurrence potentially earlier than our traditional radiological methods can. In the metastatic setting, it can be utilized to again guide therapeutic selection and monitoring potentially response to therapy. And then in the refractory setting, it can help with detecting mechanisms of resistance, allowing for appropriate therapeutic selection in a timely fashion, and then capturing tumor heterogeneity and subclone specific response. So firstly, looking at therapeutic selection. So this diagram, as you're probably very familiar with, highlights the molecular classification of GIST. And so it's the basis for how we guide therapies in GIST. And we saw in the TKI refractory setting, as we've heard already, that the secondary KIT mutational status really correlates with efficacy to our second line agents and beyond, such as Sutent and regorafenib. And then looking at the therapeutic landscape of advanced GIST, particularly, let's say, regarding the novel agents that we've just heard about, they're more specific. Many of them are very much more specific. They're targeting specific types of mutations. Therefore, we really need to be able to know what mutations our patients' tumors have so that we can guide the right therapy for them. So what currently informs our therapeutic choices in GIST? Well, it's personal. You always look at the clinical characteristics of the patient. And then next to that, it's the tumor genomics. That's so important. However, less than 15% of patients with GIST have their tumors genotyped, and we heard that earlier from your survey. It corroborated this. And the thing is with GIST, though, you don't want to just learn the molecular information at one point in time. It changes as time goes on with therapeutic interventions. And so you really need to be able to capture this in a serial way. So concordance is really key. And several studies have shown the ability to detect somatic mutations in ctDNA collected in patients with GIST. However, few studies have been able to show the concordance rate between the detection of the molecular spectrum and GIST in tumor tissue versus plasma. And so George Dimitri had a study presented at ASCO in 2013, and there's a Dutch group also recently presented data at the AACR in 2016 on this topic, and then the Decipher study really should be included here in terms of their efforts to show the concordance. So we know that detection of primary KIT mutations has a high concordance rate. However, the secondary mutations, there was poor concordance between the detection methods. And actually the plasma, as we heard earlier, was behaving in a more superior fashion, being able to detect a broader spectrum of mutations. So then looking towards monitoring response to therapy. So what methods do we currently have? Well, really it's radiological in the setting of GIST. And in our trials, we hear of radiological response assessment criteria, such as RECIST, CHOI, PERSIST. In other disease settings, they may be fortunate to have potentially a blood biomarker, although these aren't the most sensitive. For example, prostate cancer has PSA, ovarian cancer has CA125, but unfortunately, in GIST, we don't have this marker. So ctDNA is a potential blood biomarker, and it actually has quite a few advantages in that it's a short half-life, It's highly specific and accurate. And where do I see it being possible to bring this methodology? In the setting, in the neoadjuvant setting, one could argue that ctDNA could help with determining the optimal time to resection. In the adjuvant setting, it could help with determining who requires potentially imatinib, but also assessing the effectiveness of imatinib therapy and the duration of that therapy. And then in the metastatic setting, it has the ability, it may have the ability to facilitate treatment decisions in a timely fashion. So monitoring, so from what information do we already have in terms of GIST? So prospective studies have shown that changes in levels of mutational burden detected by sequenced ctDNA in GIST have been shown to correlate with tumor volume and response to treatment. So in patients who are progressing, have a greater tumor volume, that's when we often will be able to detect ctDNA mutational changes within it. So then we'll move to the detection of resistance to therapy. So resistance in GIST, as we've heard, is polyclonal. And traditionally, how we are able to capture the mutational spectrum in GIST is via biopsy. And so here you can see at the outset, the disease will have three clones potentially. We introduce treatment and the dominant clone is responsive, and let's say kid exon 11 mutant GIST and responds. And then we see the dominant mutation remaining is a more resistant population, which then grows and we see progression. We biopsy again and we're likely to need to touch on this dominant clone if at all. But there may be there are likely other resistant clones present that we failed to capture. And this is where ctDNA, you can see when it's collected in a serial fashion and where tumor cells throughout the body are all going to be secreted, the contents will be secreted into the bloodstream, and we can capture this heterogeneity more completely. The other advantages over ctDNA over tissue biopsy are that it's obviously less invasive and likely less expensive also. This is an area that we really haven't begun yet to research in terms of GIST, but I think there's huge scope. It's looking at detecting minimal residual disease. And so in the adjuvant setting, we have a lot of studies in other disease settings, such as early stage breast cancer and colorectal cancer, which have shown that ctDNA detection post-operatively have correlated with risk of relapse. This study was recently published and it enrolled 230 patients with stage 2 colorectal cancer. Post-operatively, ctDNA was detected in about 8% of this population. And in those that were positive, who had ctDNA positive results, the recurrence rate was 79%, whereas those that had ctDNA negative results, post-operatively, the recurrence rate was 10%. And actually, the prognostic impact of post-operative ctDNA detection was independent of the individual clinical pathological risk features and improved risk-free survival estimates for both the high and low risk groups. So this has huge potential, I feel, in the setting of GIST to assist with risk stratification of patients in the post-operative setting, to molecularly characterize residual disease and potentially therapeutic selection, to monitor the impact of adjuvant therapy, and to detect recurrence earlier than imaging can. So future directions. Prospective correlative studies are the ideal way to obtain data. However, it's important to note that the bigger the next generation sequencing technology panel utilizes is not necessarily the better. And a focused targeted assay could allow for maximal sensitivity and specificity, especially in a disease like GIST, where our current analysis of next generation sequencing data from tumor tissue has shown that there aren't that many recurrently mutated mutations that we see. So it probably lends itself to a smaller, more targeted panel. And then plasma genomic sequencing is aided by a quality control step to improve the performance of the test and eliminate samples with insufficient DNA for analysis. So development further, we need to determine the concordance rate for detecting the molecular spectrum in GIST between plasma-derived ctDNA versus tumor tissue, and understand how the clinical factors factors impact analysis of ctDNA. And clinical utility is hard to prove, and obviously prospective trials are warranted. Trials that have a diagnostic phase where we determine the molecular spectrum of the gist using ctDNA, sequencing of ctDNA, and then depending on the genotype identified, that we stratify patients into a particular therapy. And then we have this therapeutic phase which looks at outcomes, and then we can determine what the outcome of that was and the actual benefit of ctDNA stratification. But there are other unanswered questions, and it's important to put context of use. We have to understand the context of use. So what clinical factors influence tumor shedding and the ability to detect ctDNA? Well, do the sites of the disease influence this? And from our preliminary analysis, from our MSK data, what people with liver predominant metastases, you can detect the ctDNA much better than patients with predominantly peritoneal disease. Does it matter whether the primary tumor is in situ or resected? From a clinical status perspective, we know that progressive disease we're more likely to capture ctDNA and detect the mutational spectrum in that setting. And does ongoing treatment, this is really important, how does the ongoing treatment influence our ability to sequence ctDNA and get results? Do certain treatments reduce tumor shedding? Although they may not be working, they may reduce the ability for us to detect ctDNA in blood. And these factors may influence, obviously, the sensitivity of the assay that we use to sequence ctDNA. And so it's important to know that this has a potential to be a really effective tool when used in the right patients at the right time. And this is what we need to learn. And then nothing can go, in terms of new technology without, looking at the economics of it. And obviously, in the short term, there's definitely going to be an additional cost to this in terms of the ctDNA extraction, the expertise in the sequencing technology. However, in the long term, it's cost saving, most likely, in that it's going to replace invasive tissue biopsies. It may hopefully lead to companion diagnostic tests and therefore optimize therapeutic selection and therefore minimize the use of ineffective therapies and will guide better selection of patients requiring adjuvant therapy. So in conclusion, ctDNA has the potential to be a blood biomarker of clinical and molecular behavior of GIST. Further development is required. Sequencing technology is improving, and we need to improve the sensitivity or ability to detect the molecular spectrum of ctDNA in GIST. Routine collection of ctDNA in prospective clinical trials is necessary to advance this technology forward, and thankfully we're seeing this in the trials that we have ongoing at the minute. And what will this bring? Integrating sequencing ctDNA into trial design. It'll hopefully yield information regarding the concordance rate between detecting the molecular spectrum of GIST in tumor tissue versus sequence of the DNA and lead to companion diagnostic tests. It'll help hopefully in terms of developing it as a complementary method for response evaluation and guide therapeutic selection in hopefully a more efficient manner. It'll help with describing the plasticity of GIST cells during the metastatic process. We're going to learn more about what this tumor is doing as the therapies are introduced, and also hopefully potentially identify even more new methods or mechanisms of resistance that we potentially could target down the line, and track tumor-specific subclones looking at a molecular basis of response to our therapy. Thank you.
Thank you very much, Ciara, for sharing your in-depth knowledge about the ctDNA. We are almost on time, Sarah. Maybe there is one question Ciara would like to answer.
Yes, just a couple. The amount of blood you need to make this, is it 10 millimeters, not milligrams, not less?
No, well, I think as time moves on and potentially the technology improves, maybe that volume I expect it will likely decrease, but currently for the methods that we're using now, it needs to we take 2 samples of blood in order to be able to detect.
And if you compare the cost of doing a sample in the blood against tissue, how can they be compared?
I suppose in terms of the actual sequencing technology, they're similar, so that cost will be the same. In terms of the actual performing a biopsy, the cost versus taking a blood sample, right. I probably don't even need to elaborate on. Yeah.
Thank you very much.
Realistically, how long will it take to get from where you are now to this becoming sort of standard practice, do you reckon?
Well, let's just take the lung cancer story as an idea, looking back to in terms of history. So we had a guideline in 2013 saying we should be testing a molecular spectrum in lung cancer using tumor tissue, and 3 years later we have the FDA on the basis of a pivotal study showing that the concordance between ctDNA and molecular spectrum detection versus tumor tissue were very similar. So I think, with our new studies, we should be looking, and that's why ctDNA and cell-free DNA collection has been incorporated in these trials so that companion diagnostic tests can be developed. And it's in the best interest of everybody, both industry, society, just patients, that this is the case. It minimizes the use of ineffective therapy and helps patients receive effective therapy more efficiently. So I think it could be quickly in terms of, let's say, the role of it in terms of monitoring response to therapy, and let's say in the adjuvant setting, more studies are going to be necessary before we can bring it in there. But in terms of a companion diagnostic test, I think that's where we'll see it first.